So thank you very much, Melanie and Janine, for asking me to talk. The first thing I realize in this new world of Teams is that you have to choose your shirt carefully. And when I looked at my image of my shirt, it is fairly glary on the video. So sorry about that. Anyway, my remit is to talk about bowel cancer screening. And before I do that, I'm going to tell you who I am. I'm Director of Gastroenterology at the Townsville Hospital. And I've worked at TUH now for 23 years. And I also work in a private gastro NQ. But more importantly, why am I an apt person to talk about bowel cancer? Well, in 2006, I rode solo from Sydney to Townsville to raise money for bowel cancer research. And then in 2009, I rode the length of Britain for bowel cancer UK research. And during that time, I stopped at Lions and Rotary clubs each night and gave a talk on bowel cancer and the importance of screening. And on that first ride, when I got back to Townsville, my two young girls, which are now at university, gave me a big princess hug. So there you go. The information I'm going to use today comes from the Cancer Council, and this is a very strong and up-to-date guidance. Up-to-date guidance for us as professionals, and the link is there. But the two practice guidelines I'm going to take from are the clinical practice guidelines for prevention, early detection, management of colorectal cancer, and the clinical practice guidelines for surveillance colonoscopy. And I'll talk around those. This is what you see when you go to the website, and I would highly recommend any of you using it. It's a comprehensive and frequently updated website, and it has obviously other cancers there as well. So what's the size of the problem and how common is colorectal cancer? Well, it's the second commonest cancer in men and the second commonest in women. In men after prostate, in women after breast. It's the second commonest cause of cancer death after lung cancer. And you can see here New South Wales data, which is the same of ours, is the lifetime risk of 1 in 11 men, 1 in 15 women, and the male is greater than female. So why do we get bowel cancer? Well, there's clear environmental and clear genetic reasons for getting it. Environmental include red meat, particularly barbecued, cured meats such as hams and sausages and salamis, excess alcohol are all increase your risk. Fiber, vegetables are protective. A normal BMI is protective. So the tendency of society to have increasing BMI significantly increases your risk. Exercise and calcium are protective, and aspirin is now clearly shown to be protective even at low dose. And the other factor is polygenetic, so your inheritance of genes from mum and dad, and in most people that's multiple minor gene defects that lead on to bowel cancer. But then also there's associated conditions such as inflammatory bowel disease, Crohn's disease, colitis, and then the rare but devastatingly important single gene mutations such as familial adenomatous polyposis and Lynch syndrome, which we'll touch on later on. The important thing we need to know about bowel cancer is in the young people, it's uncommon. But with increasing age, particularly after the age of 50, the incidence increases both in men and women dramatically. And in the 70s, a guy in America called Vogelstein postulated the mechanism of which bowel cancer develops, which is from normal bowel through to small adenomas, larger adenomas, and then to cancer. And you can see along the bottom, this takes many years, decades. And along the way, new mutations are developed, and they're what allow you to move from one stage to the next. And graphically done in another way, we can see moving from normal to invasive cancer with multiple genetic mutations sending us along the way. And probably if you have a family history, you probably gain one or two of these minor mutations, which allow you to pass along this pathway quicker than if you didn't have a family history. So I want to talk first of all about population, or what we'd call average risk screening. This is not, I'll repeat, not for patients with symptoms or for patients with increased risks of family cancer. They do not fall into this group. Symptoms need to be treated on their own merits, and people with family history fall into higher risk, not average risk. The World Health Organization tells us about the ideal characteristics of a screening program. You need a detectable cancer or early cancer, and you need to have interventions and safe screening tests. In colorectal cancer, we're very lucky because we know that the incidence really takes off after 50, so we can target an age group. We know that we can find a pre-malignant condition, a polyp, that if removed will not develop into bowel cancer. And there is good evidence that early detection of even cancer has a much better survival. So by these characteristics, we can determine that bowel cancer screening is going to be effective. The programs vary vastly around the world. In America, you can choose from multiple modalities. In Germany, everyone gets a colonoscopy at the age of 50. In Australia, Britain, and some other European countries, we have fecal occult blood testing. So survival and stage, I just want to emphasize this. This is the old staging program for bowel cancer, Dukes A, B, C, and D, and just limited to the wall, through to lymph nodes, through to distant metastases. But you can see if we catch bowel cancers before they cause symptoms, when they're very small, the survival rate is very, very good. If we wait until they have disseminated disease, survival at best is 10% and very poor. So this is what we're hoping to do with screening, is to catch A's rather than C's and D's. And there's good evidence that screening does that. So population screening in Australia is fecal occult blood test using a fecal immunochemical test. And there's good randomized controlled trials in other countries to show a reduction in mortality of around about 30% using fecal occult blood testing. The key to this, though, is it's not one test, it's multiple tests over years, even decades. So we start at 50, we finish at 75, and we'll talk a bit more about why we finish. And then it's every 2 years. So one negative test is not a celebration of I am free of cancer. It's the multiple tests. So the fact that someone has a negative FOB in their first round and then starts to develop symptoms shouldn't reassure you that they haven't got bowel cancer. It's this multiple repeated testing that will pick up a proportion of people that are losing small amounts of blood from cancers or polyps. Test then goes to colonoscopy to look for polyps and cancers, and the screening program says that should be within 120 days, but I'd suggest that's a long time to leave uncertainty with a patient, so I think it should be within 30 days. So the National Bowel Screening Program, just a bit of data, the participant rate is around about 42%. 8% of those have positive results. Now, immunohistochemical tests can be adjusted its sensitivity, so you can actually adjust the positive rate to how much blood it will pick up to suit your population and its needs. Sorry. And data so far says of those screened, 1 in 29 will have a colorectal cancer, 1 in 8 will have an adenoma of those screened. And if you have a normal colonoscopy and screening, then you then should re-enter the program after 4 years, because you don't need to go immediately because you've had a negative test. So managing patient risk for bowel cancer is really what it's about. I'm going to spend a minute or two talking about that. So if you have symptoms, direct to investigation. No symptoms, average risk, that's the National Bowel Screening, 2 yearly fecal occult blood. But above average risk, we look at family history and other markers, and that then is governed by colonoscopy to determine whether there's pre-malignant conditions. So if I go into the three categories in the guidelines of personal risk, category 1, we've talked about average risk, only slight increased risk, or only slight increased risk. So if you've got no personal history of colorectal cancer, polyps, or inflammatory bowel disease, and no family history, your average risk. If you have a weak family history, only a first-degree relative, or one first-degree relative, second-degree relative, over the age of 55. So what it's telling you is if your relative is 55, we're not going to count that in our risk stratification. Then you go into average risk, and you've got a 5 to 10% lifetime risk of bowel cancer, and you go onto FOBT testing. Category 2 is moderately increased, and they're a first-degree relative under 55, or 2 first-degree relatives of any age, or a first-degree and second-degree relative of any age. So this is a cumulative genetic predisposition because of your genetic makeup from your close relatives. And these patients have a 15 to 30% lifetime risk. And we'll talk soon about their management. And the last group is category 3, which has got a high risk. Their risk may be 7 to 10 times the general population. And they've got multiple first and second degree relatives of young age, some of young age, or they have a familial syndrome, one of which is Lynch syndrome, but we'll talk more about those multiple cancer syndromes in 2 ticks. So one thing you may notice is we used to talk about 60 years as the age at which there was a significant family history. And you can see that they are lowering that and they're tightening that because it's clear that the older you get, the more likely you are to have cancer. So someone who's 90 is much more likely to have cancer than someone who's 30. So if you have a relative who died of bowel cancer at 90, the genetic input that they have to you to increase your risk is much lower. And so that's why they've taken 55 as the age from 60. I mean, the studies would back that comment up. But what this is, it means that 65% of family histories are considered weak and therefore leave patients in category 1. So not all people with family histories immediately need to go into a higher category. And therefore, almost 90% plus of the population fall into that category 1 personal risk. So if I just say how we screen those 3 categories, category 1, average risk, FOBT, I've told you a few times. Category 2, moderately increased, colonoscopy starting at the age of 50. And there's an option in the guidelines to start fecal occult blood testing, not through the National Bowel Screening, but just between the GP and the patient at an earlier age. And then category 3 are high risk, and they have colonoscopy at increased frequency, sometimes annually, depending on the strength of history and what type of syndrome they have. And I promised I'd mention the types of syndromes. Well, these are the 5 main family syndromes, and we don't need to remember them in detail, but familial adenomatous polyposis, FAP, that's the APC gene, MUT2 associated polyposis, Lynch syndrome, which is a mismatch repair, juvenile polyposis syndrome. Juvenile describes the type of polyp, not the fact it happens in kids. And then more recently described, these sessile serrated polyps and serrated polyposis syndrome. And so all of these have their own screening programs which are beyond what we need to talk about tonight. When you do have these high-risk cases, genetic counselling and testing is often important. And you have to remember that many of these have extra colonic cancers. For instance, Lynch syndrome has an increased instance of ovarian and uterine cancer, and they need screening in their own right. And in some of these, FAP, for instance, the lifetime risk of bowel cancer is 100%, and often it's not, and surgery to the colon is necessary. And those guidelines I've just told you are summarized on a nice sheet that is here that tells you the risk and how to screen. And that's taken from the guidelines. We are noticing, and people have commented a lot in the press, that we're seeing bowel cancer in younger groups now. And unfortunately, the guidelines haven't embraced this, but studies have shown it. Why is that? I would think it's our diet and our increased BMI that's probably the main driver. And I think that with time, guidelines will catch up with this and will change. But at the moment, we haven't got many options, and one of which would be in-house FOBT starting at a younger age, or deciding to send someone for colonoscopy. That last comment is more controversial. But remember, whatever age you have, if you have alarm symptoms, they need to be treated in their own right and investigations initiated. Now, everything I've shown you so far does show that colonoscopy is a vital part of this surveillance program, whether you go via FOBT or direct because of a family history. So the year before last, the clinical standards nationally for standard of colonoscopy was published, and that does give very clear guidance to high maintenance, high standard colonoscopy. There's no point putting someone in a screening program if you perforate lots of bowels and cause more damage than good, because many of the people will not have pathology and are asymptomatic by definition. And also, if you haven't got high quality and you miss lots of polyps, it's a waste of money and a waste of patient time, exposing them to risk without benefit. So this gives very clear guidance to people that perform colonoscopy and institutions that perform colonoscopy of the standards they should meet. So we've talked about screening there, and I'm now going to go briefly on to polyp surveillance. So screening is when you haven't got a condition and we look for the condition in you. Surveillance is when you've been detected as having the condition and then we're monitoring you. And so really in surveillance there's two areas: follow-up of polyps. So people who've had polyps, either tubular adenomas or sessile serrated polyps. This is what a tubular adenoma looks like. This one is pedunculated, but some of them aren't. And this is what sessile serrated polyps look like. They're much harder to see with indistinct surfaces. And the other group we follow up are people who've had colorectal cancer, and the timing and follow-up for those. This surveillance depends on your age, the number of polyps that you have, the size of those polyps, particularly if it's greater than 10 millimeters, the type of polyp. So villous adenomas are more dangerous. And then are there any high-risk features? High-grade dysplasia is that polyp slowly turning to cancer. So it's at a greater risk if you've had a high-grade dysplastic polyp. It shows that your genetic makeup allows those steps to be reached. So recommendations for surveillance do vary a lot around the world, but they have those general theme on number, size, etc. In Australia, we currently have two guidelines, the Cancer Council guidelines, and really what have just come in, which is the new Medicare numbers, which aren't really guidelines, but they're an attempt to stop overvigilance, because we found that we're probably overcautious. Now, some would argue that's because we get paid for doing it. Others would say we don't want our reputation blemished by missing lesions, but it's probably a complex reason why we overlook, and these item numbers are trying to restrict that. So I'll show you in a second of those. So this looks like a complicated graph at first, but if I just show you that we're looking at total number of polyps, then we're looking at size of polyps, 10 or more in millimeters, and then we're looking at high-risk features, you can punch your patient quite easily into this graph and find out whether they need a 10-year review, which what the guidelines say, but few clinicians actually use, but I'm sure will into the future in this very low-risk group, all the way to this highest risk group where many polyps, high risk, big in size, you come back in a year. So this tells you that from anywhere from a year, 3, 5, and 10 years would be an appropriate follow-up for your patient. And these are the Medicare numbers for symptoms, for number of polyps or family history. And this is to try and restrict overuse by attaching a number to the reason you're doing the colonoscopy. And I think this will have some impact. So what's very important, I feel, is the age and stopping of screening and surveillance. National Bowel Screening says quite clearly we stop at 74. And that's due to the balance of risk and benefit. Even though their risk is their benefit will increase because their risk of bowel cancer is increasing, so does the risk in these more elderly people of actually doing screening and colonoscopy. Plus, we're removing a polyp that may be small, that may not cause any problems for 10, 20 years. So you can ask what's the benefit to that patient of doing that? And if you're an economist, restricting your age saves you dollars. And then for polyp surveillance, I think it's quite clear that we need very careful consideration between the ages of 75 and 80. And if people have significant comorbid disease, they're far more likely to die of that than they are from having a small polyp removed. So if they had their last surveillance colonoscopy at 75, you could argue that should be the end of it and that they probably don't need it. Now, some elderly people have more advanced polyps and are very fit. Some elderly are fitter than some 60s. So that does need some window of opportunity of flexibility. But there's pretty clear recommendations now that over 80, the risk-benefit profile is poor. There are always a few exceptions. And I feel that many elderly people get into the trap between the GP, the gastroenterologist, and themselves, and they're all waiting for someone to blink and say, you don't actually need a colonoscopy. And I find many patients who I say, well, really, the risk benefit is not in your favor, go, thank God I've escaped this turmoil of recurrent colonoscopy. And we have to remember that it's not just the risks of the colonoscopist perforating or doing something like that during a procedure, but it's the person who goes home and trips. I had someone getting into their car with their relative trip and break their arm. Some people go home and have an amnesic event. And in fact, this week I had an elderly gentleman who's ended up in Air Hospital with delirium after his colonoscopy sedation. So we do have to get that balance right. Just last couple of slides, reducing future risk of colorectal cancer or polyps. I think discussing lifestyle and diet, BMI, with your patient. Consider low dose aspirin. Again, this is a risk benefit. You don't want them to die of a bleeding ulcer, but save them from bowel cancer. But it's clear that this does reduce polyp formation in patients, even at low dose, 150 milligrams. Consider screening family members. So if you've got an index patient, especially if they're young, you should tell them to have their family members screened. In the complex cases, don't forget genetic counselling. And I think it's important for the proceduralists to give clear follow-up instructions and to have a recall mechanism in place. So conclusions, bowel cancer is common cancer. It's an ideal for screening and surveillance because of the long interval between polyp formation, early cancer, and then disseminated cancer. The Cancer Council have really comprehensive, easily accessed guidelines. Management depends on assessing the patient's risk, which I've told you, into those 3 categories, and quality colonoscopy is key to effective screening and surveillance. So on that, I'll leave you with a picture I took with my iPhone about a month ago, walking the dog up Castle Hill goat track. And thanks, and any questions.